Thank you very much. And if we could continue with that theme, I really appreciate that you distinguish what chaplains do not do, push religious agendas and proselytize. Could you speak briefly about what does a chaplain do on the team? Because I think we make assumptions about roles, and it would be helpful to have that clarification.
Yeah, thank you so much for asking. So a chaplain is in some ways a Jack or Jill of many trades. So for those of us in the serious illness care workforce, we know that holistic, whole person care, as I said, is very important to patients, to their loved ones, to their families. So a chaplain on a team taking care of someone with serious illness can address those spiritual, sometimes religious, existential concerns that arise with regard to the shifts in meaning of life when you're diagnosed with a serious illness. Your values shift. Things that are important to you become more front and center. Some of the spiritual pain that can emerge, and again, separate from religious pain, that pain of lost hope or fragile hope, changing projections for your life, your relationships. We are able, as I said, to walk alongside the patients and their loved ones, helping them use their own internal resources that we all have as kind of human beings wired to pursue meaning and purpose, and help folks achieve maybe not cure, but healing, wholeness in the midst of living with a serious illness. Chaplains are also a fantastic resource for interdisciplinary team well-being and general staff well-being. That's kind of what we do. To use a religious language term in a way, we can be kind of the shepherd, clergy, pastor, companion for the team and address burnout issues, moral distress issues, ethical dilemmas. We can be an expert and a guide in that.
Great. Thank you very much for the clarifying response. The next question is for the panelists, and you can, if you choose to respond to the question. The presentations this morning talked about the great work that many, if not all of you, are doing. I'm wondering if each of you could speak briefly about a challenge or challenges in the work that you're doing, the care for people with serious illnesses.
I think people know I have so much to say. That's the challenge here. So, one of the issues that we're trying to work through, right, is that the specialty workforce in its sort of a formal, recognized way is still relatively young. I mean, I did my fellowship in 2009, so that was a decade ago, which doesn't feel that long ago. And really the training, particularly in the physician space, has ramped up over the last 5, 6, 7 years. So we're both trying to run fast, but also get our legs underneath us at the same time, right? So it's a herd of a bunch of young but really passionate folks who are learning a ton from a lot of folks who've come before us as well. So I think part of the challenge is figuring out issues like the dose, like how often does one need to be seen by a palliative care team to make the effect that we think is important. One is also sort of the frequency. What are the time intervals between where it would make sense to see folks, particularly in the non-acute care setting? What are the quality measures? What would we consider to be the sort of the minimal pieces that should go into the first evaluation for the second versus the third? And so our simultaneous challenge that I see is both identifying what is high-quality palliative care, which we've done in a lot of ways, but also trying to figure out what are the challenges of the implementation of those pieces. So it's important to have guidance, which we have from the NCP and others. It's also important to think about what's the distribution of that across different regions in the country. So what does that look like to do, for example, guideline 1.8 in the NCP is, having programs to address burnout and resilience. But that might look different in a hospice versus a community-based palliative care organization for a hospital-based palliative care organization, et cetera. So what that looks like, the implementation of it, remains still a little bit of a challenge to work through. Then you have to think about, well, who on the team might lead that, and in fact might be a chaplain. with social work and others. So that's one of dozens of guidelines that are there. So I think what we have to simultaneously do is recognize that we're learning while growing, and that the population we're taking care of is also growing, and we're learning what complex needs look like, and understanding social determinants of health and issues regarding equity of care and other things that we're learning alongside everybody else learning. And that's our challenge. But I know we're up for it, because ultimately what we're saying is this is part of a cultural change, right? That serious illness care, if we only looked at patients as a disease or as a stage or as a prognosis, which is frankly what I think a lot of persons with serious illness were worried about, is what we were doing. That when we look at them, we see a magical clock on top of their head that tells us something about where they are in some continuum. And now that we're sharing with them and the rest of the health system that this is actually about looking at another human being and kind of just saying, like, what makes your day hard? What does a good day look like? And how can I help you get there? Is ultimately what this is about. That in that cultural change, I know we'll do this really well.
Thank you. Thank you.
So I think I face the same challenges as you, Dr. Kamal, just in a slightly different perspective. I think, when it comes to health services research and labor force issues, it's the same thing. It's always more difficult so the field is moving so fast. And when you have that happening in a sector of healthcare, and there's new occupations or evolving occupations, and it's just going at full steam, people are, you don't have time to develop the evidence base, right? And you don't have time to gather the data needed to power the evidence base. And so I think that's what we struggle with is, your experience with care is similar to our experience with sort of the research end, that things are just simply moving so fast. We don't have data and information that would answer some of the policy and programmatic questions and help, give people a path, if that makes sense. So I think we have a very analogous problem.
Thank you, Dr. Waska.
I think on the education side, there are some similarities in what Dr. Kamal spoke about in terms of this being a young field, building educational programs and recruiting candidates and learners into those programs across the interprofessional team, and kind of as Denise was alluding to, recruiting candidates into certification programs or to take certification exams. I think on the physician side, we face a lot of challenges with existing structures and models of how we are building and delivering educational programs, and other professions on the palliative care team are building those programs and at the same time. So for example, I think on the physician end of things, traditional physician fellowships are 12 months. Physicians match into those programs through the National Residency Match Program. And what we know is that we have an insufficient pipeline even into our existing fellowship programs. So in 2019, we had 355 physician positions offered in the match program, and we didn't fill those positions. Only 342 candidates applied to those fellowship positions, so we didn't even have enough applicants to fill the positions that we had. And then when we looked at the match data, there were only around 280 candidates who matched. So there were 70 unfilled physician positions in the match. We're nowhere close to a number like 575 positions per year that would be needed to grow the physician workforce. And so I think that it just really demonstrates the constraints of our traditional model. Some of those constraints are related to recruitment into the field. Others are related to funding. So CMS residency funding caps have not increased for physician training since the late 1990s with the Balanced Budget Act. And so that really limits institutions' abilities to grow traditional training programs. And so I think that, as we seek to change and really fundamentally rethink how we recruit candidates into training programs, whether that's physician programs or other disciplines, accessing individuals who are mid-career, who are bringing expertise and can go through a specialty training program are really important. But that really is a fundamental change in how we think about recruiting a specialty workforce into educational programs for certification and board eligibility.
Thank you.
I would add to that chaplains, I think we're under no illusion that we will be a large enough workforce anytime soon. We have really limited workforce data. One of the recent surveys done just looking at chaplains working in Catholic healthcare settings showed that our average age of a chaplain was 60 years old. We're guessing if it was a more complete survey that age would be slightly younger, but we are often a mid-career or second career choice, and so I think we're always going to be an older workforce. With that said, one thing I didn't highlight that is, I think, the chaplain pathway forward to navigating the shortage is that chaplains are also excellent educators for the rest of the interdisciplinary team on what it looks like to screen and take a spiritual history and get a general sense and notice when spiritual distress, spiritual pain, spiritual issues might be present. And then, like the typical generalist specialist model, grab and capture one of those more trained or board certified chaplains to address those needs.
Thank you. We want to make sure that we open the floor for questions, and we'd like to transition to that point. And it seems like we have some persons ready to pose questions, so please do.
Great. Thank you. James Tulsky from Dana-Farber Cancer Institute in Boston. One of the issues that I find really interesting, I struggle with in my own role, is trying to define what the roles are of each member of the interdisciplinary team, how we have each person practice at the height of their scope, and yet not be redundant. And this is particularly, it's less of an issue when you're somewhere where you don't have other members of the team. So, for example, if a nurse practitioner or a physician assistant is out practicing by themselves or supervised at some level, but relatively independently, that's one thing. What about places where, like at ours, where we have those same people in the same team? So what is different between the role of a nurse practitioner or the role of a physician? How do we make that work best? If they're simply the same and they're doing the exact same work, then we ought not be, then that makes no sense, right? They're getting paid differently, they're getting structured differently. So I actually have two parts to this question, but the first one would be, how do we do that, and what sorts of thought have all of you given to that issue, and how do you think we should be resolving that?
That's a great question. One of the things that I think about, and we do and fund a lot of research on, is around productivity and team makeup and FTEs. And so one thing that I think about when in your example of, using a nurse practitioner or a PA, for example, as a physician extender, is we already know that there are shortages, and a lot of demands on physician time, for example. So perhaps it's not that as much of an issue that what they're doing is redundant, but if it reduces the physician time on the team, and they can use the time mix of the team, the time composition can be shortened or extended for others. You get the same amount of care and the right mix of care, if you will, but it just shifts sort of the FTE time, if that makes sense. Is that? Have you?
I think that we figured this out in some places, and I personally don't think we've figured this out in palliative care. So, for example, I practice in a cancer institute, and the oncology practices, I think, have figured this out. So the oncologist sees the patient at the treatment decision-making points, branch points, so like every 4 visits or something like that, when, for example, there's a scan. And then the nurse practitioner sees the patients in between for sort of maintenance care, supportive care, and so forth while the patient's on treatment. That seems to work very well. I've actually not seen a place in palliative care that has really carefully thought this one out of what that balance is. I tend to either see redundancy, where both a nurse practitioner, for example, and a physician sees the patient together, and and not sure how that works, or I see them in completely independent practice, where they're essentially doing the exact same thing. And again, I don't understand why that should be. So that's the part that I struggle with.
I think you've given us a lot to think about, and because we have so many people waiting to ask questions, I'm going to go to my left side of the room to take a question. Next.
See, can you hear me? Yeah. So first of all, I want to point out the radical nature of what Laura Dingfield is doing at Penn. There are two elements to that. One is that she was able to secure permission to pilot this from, is it the American Board of Internal Medicine? So think about the implications of this to all specialty training in the U.S. That we have specialty training that has been for decades based on you do X number of years, and unless you do something egregious, you get out at the other end. Okay, and that is the case for cardiology, oncology, GI, surgical subspecialties. It's time-based. And there really isn't a rigorous competency testing that people have to go through to get out on the other side, other than the test, the board exam. And anybody who's taken one of these board exams knows that they have highly variable relationship to the competencies that are needed to take care of patients. So the first thing is she got permission to say, no, it's not about the number of months. It's what do you know? And can you deliver on those skills? Can you demonstrate your competency in those skills? The implications of this are really profound and revolutionary for graduate medical education. And I'm proud of our field for conceptualizing that and actually getting permission to pilot it. And others are following in Laura's footsteps. So both the competency thing and the time-based thing. So much of physician training is you do 4 years of undergraduate, you do at least 3 years of your major specialty, you do, 2+ years of your subspecialty, because that's the way we've always done it, not because we have any data on outcomes from that educational model. And I think this is the camel's nose under the tent. So since I have the mic, can I ask one more question or make one more comment?
Sure.
Okay, sorry. Michelle Washko, I'm really interested in whether you can give us some examples of your work on workforce distribution, adequacy, competency, and so on, influencing policy. And what can we as a field do to ask the right data questions that in turn will enable us to influence the kind of policy changes that Arif laid out in his talk?
Sure. So an example of how some of the work that the center does has actually impacted policy. I mentioned the projections, just sort of generally, that we do. Now, this past fiscal year, 2019, was the first year that Congress had actually appropriated funds for a medical student education program based on our projections. The eligibility for that program, you had to have a program located in states where we had predicted primary care shortages. So that's just one example. What I would say is to improve the data and the quality and sort of as a field move it forward. I feel like there's always a better case made when you're better defined. I've seen the same discussion or situation play out more recently in the behavioral health arena. We end up with a public health emergency, and then there's a scrambling. And there's a lot of occupations. There are some core ones that have been tried and true and recognized, but there's a whole lot of others that are obviously helping, obviously emerging, but there's very little information out there about them. To me, the best way are things like you start gathering that evidence through surveys, things like that, and then you kind of coalesce. That to me, then you if you get far enough, you end up trying to get yourself classified as an occupation with the federal government. Then you get counted, because then you're counted by all the federal statistical agencies, and then money can start to flow. It's a long path, but that's kind of the way it goes. And that's a very 100,000-foot level answer.
Thank you for your response. And just a reminder, if we could please keep the question and comments brief so we can give everyone an opportunity to ask a question or make a comment who has. Thank you.
I promise. Good morning, everyone. My name is Darcy Graves, and I am currently with the Centers for Medicare and Medicaid Services. But speaking as a former medical school faculty member, I just wanted to underscore the tremendous resource that chaplains are. 20 years ago, I was asked to develop a communication skills course for medical students at the school that I was at. And so as the process of developing the course, I was able to partner with one of our hospitals had a chaplain training program. And so we partnered together, and we were able to utilize student chaplains to help facilitate small groups for our medical students so that they could learn about communication skills in a less yes-no question format, and actually eliciting those sorts of questions. And then we also had experiential exercises where students had to leave their white coats at home and got to shadow chaplains in the hospitals on their rounds. And again, seeing them engage with patients in a non-clinical, trying to get through it sort of way, and hearing that more holistic story. So, and that was 20 years ago. And so I'm thrilled and sad that we're still talking about these things, but there's such a tremendous resource. They have so much opportunity and ways to give, and I think they're an essential part of the team. So I hope we can continue to be creative and inclusive in those training and teaching opportunities on both sides. So thank you.
Thank you very much.
Can I just say, what Darcy didn't say is that curriculum was at the medical school that I attended 20 years ago, and I wasn't going to out you. But it's wonderful we run into each other again like this. The point being is that impact at the undergraduate level, which is where I was at, has made a lifelong impact. So remember the importance of those things across the continuum. I can't emphasize how impactful that was, because I remember that curriculum. I remember I didn't even know what the term palliative care meant, nor was that not my career trajectory. And so to your point, making that impact regardless of the profession the person's going to go into, this is about teaching humanities skills, right? And that's the underpinnings of everything we're doing. So yes, very important.
Thank you. Thank you for your follow-up comment. Yes.
Hi. Hi, I'm Phil Rogers. I'm here today representing the American Academy of Hospice and Palliative Medicine. For those of you expecting Joe Rotella, I'm sorry he's not here. You're stuck with me. I also direct the adult palliative care program at the University of Michigan, where we have a full interdisciplinary team. And I'll briefly share the chaplain and social worker love. You are incredibly high-value members of our team. And I want to amplify something that Denise said. Not only are those members of our team incredibly important, essential to our patient care, but they are the core of our team care. They take care of us. They keep us honest. They're a moral voice for our patients and families. They're a voice for justice, and they just make us better. My question is to the group, and actually to our presenters on the phone, even if they're with us still. We're engaged in building a fully interprofessional graduate training program. We have fellowship training programs in medicine, advanced practice nursing, CPE, and trying to get funding for a social work fellowship. And I was interested in this idea of the emerging work on standards for interprofessional education and interprofessional and certifying interprofessional education teams. And I heard a little bit, I believe from Ms. Valentine, on the maybe pros and cons of establishing even a separate accrediting body that seems like it has potentially lots of considerations. I do think, however, that it's important for us to think together about what those standards for interprofessional education are, because we find that it's an incredibly vibrant environment. We're among the most sought after teams to work with in all of the schools because people love to learn that way. So I think this is a real opportunity, but I think it's incumbent upon us to sort of understand where we set the bar, how we do that, and how we can sort of demonstrate through competency-based education that we're doing the right thing the right way. So I would love to hear your ideas on how that can grow and emerge.
Thank you for your question. Are we able to have one of our virtual presenters to respond to the question? Since that was a specific request. If not, we can...
I think I can respond. This is Barbara. Do you hear me?
Yes.
Oh, great. Great. I don't know that we've set any kind of standards for interprofessional palliative education, but the Ipek Group, which is a group of the different disciplines involved in healthcare, came together and they did set core competencies for interprofessional education and key domains, which include roles and responsibilities, communication, ethics, and one other that doesn't come to mind yet. But I do think that as palliative care leaders, we would be very important into setting those kind of standards because our whole practice has been based on that. So that's work for the future, but I agree that that's needed.
Great. Thank you for your response. And we'll, in the interest of time, take another question.
Yeah, I think I have, this is Brenda Nevajon. I have a two-part question. One has to do with the slide that Jennifer Valentine showed about advanced practice nurses and their scope. And you heard Dr. Tulsky mention about practicing to the scope. And so what her slide showed was the patchwork across the U.S. of scope of practice. And so as you build teams and you build models and standards, where does licensure come into this? And I'm not as familiar with social work and chaplaincy in terms of your licensures. And then also part of that then is then at the certification level, because the certification is on that added competency, knowledge, skills, but it's also, you still got the licensure issue. So I guess it's the interplay of that as a specialty is developing. Any perspectives on those? Thank you.
Thank you very much. Do we still have Jennifer Valentine on? If so,
yes, I'm here.
Would you like to respond or comment, Jennifer, since the reference was specifically to your presentation?
Well, I think the difficulty is that these things vary state to state. And so if there's going to be any consistency brought to it, it would have to be a state by state effort to bring things into alignment. And having worked on a couple of different initiatives that has worked at that level of the state by state, it's incremental, it's slow, and there's all kinds of interweaving, overlapping considerations that have to be dealt with. So, as I said, in putting forward the recommendation, how likely or plausible is it that we could get to a degree of consistency across the U.S. is perhaps fairyland, but it is something to think about and to strive for.
Yeah.
Okay, great. Thank you.
My second part of the question had to do with data, and when we show data. So we have national, like there is you mentioned the registered nurse survey. We know our specialty organizations like the Hospice and Palliative Nurses Association and the Certification Corporation there has data. Probably our medical specialty organizations do, but how do we eventually really get to a reliable database so we're not saying, well, I think there are about 7,000 of those and maybe 5,000 of these. I don't know if that was partly what you were answering earlier, Dr. Washko.
Yeah, it was. It's something we're just sort of, when I referred to the U.S. data being good but not great, that's a big piece of it. And it's not one occupation, it's throughout healthcare. I mean, on one end of the spectrum, you have occupations like physicians and surgeons where you think, well, it'd be really easy to get a census count and, not have to rely on estimates, and because we have things like the AMA and you have MPI files, but each of these data sources are different and they don't always match. And then on the other end of the spectrum, you have folks like peer providers of behavioral health where we have nothing. So, that's exactly what it's.
Great, thank you. I wish we had more time. We're close to about 5 minutes or so left, so I'm going to take a question. Hopefully we can get to everyone who's waiting.
Okay, I'll be really quick. Dr. Washko, are there any areas where there's going to be a glut in medical specialties? Or are we just facing an across-the-board physician shortage in everything?
A glut. No, I wouldn't say there. I mean, I'd have to go back occupation by occupation, but I wouldn't say there's a glut or a massive oversupply in any. I think when you get into some of the subspecialties, but it's all hypothetical, right? I mean, that's the issue with projecting. You're kind of saying it's all a what if scenario. What if this changes? What if that doesn't change? So at the best, there's a gentleman who's been doing health workforce research for many years, and he says projections are like totems, and that's really are. They're right. They're showing a trend. So what I would say is no. I think the bigger problem is that maldistribution issue, and if you can balance the maldistribution with some of the quality and the scope of practice issues, I don't want to say the sufficiency will take care of itself, but it becomes minimized as an issue. Does that make sense?
Okay, great. Thank you. Back to the right.
Yes, good morning. Thank you. My name is Amy Melnick. I'm the Executive Director of the National Coalition for Hospice and Palliative Care. I want to thank you all for an excellent panel. Just a side note, if the National Consensus Project clinical practice guidelines for quality palliative care were mentioned this morning, they're all available for free download at our website, National Coalition, HPC/NCP. That's not my question. My question really is for Dr. Washko. Is there a role at all in terms of increasing access to providers through the National Health Service Corps and loan repayment programs? And the reason I ask is there is new legislation. It's sort of been kind of floating under the radar. It was introduced a couple of months ago by Senator Rosen. It's the shortest piece of legislation I've ever seen. It's like a half a page, but it basically inserts palliative care into the Public Health Service Act, where it allows providers who are specializing in palliative care to access loan repayment through the National Health Service Corps. Could you comment on that?
Sure. I mean, I think the answer is yes. The National Health Service Corps is truly, in my opinion, it's about access, right? It's increasing access in areas that are the most underserved. To the extent you have a need for a certain specialty of any kind, that's exactly what its purpose is. So I mean, I realize that's sort of a blanket statement, but I know that there are several occupations where legislation has been introduced over the year to get them included. I know that there have been efforts to improve HPSA, the Health Professional Shortage Area designation calculations and things like that. But I think the short answer is definitely yes. I mean, it's really, truly the intent. And we're now actually, my center is just starting, it's very nascent, research on trying to calculate some of the outcomes for the NHSC, one of those broad bucket domains being access, actually. So I think once we're able to do that and get that kind of work going and out publicly, I think that could have really interesting implications for future proposed legislation.
Well, thank you. I didn't announce it. It's the bill number, for those of you who are interested, it's S1921, the Provider Training and Palliative Care Act. And again, I think it's something that organizations that are interested need to kind of demonstrate their support and let Senator Rosen know this is something that we support. So thanks.
Thank you very much. It looks like we have questions only to my right currently, so we'll take the next one.
Thank you, panel. That was really an excellent panel, and I also want to commend the speakers for presenting actionable recommendations. And it is a great pleasure to see HRSA and others in the room. I want to call out Joan Weiss in particular, who's been an incredible advocate for the field. So the one remark that I have is that in terms of the presentation, we lacked the nursing data, and the nursing data does exist. So because the nursing data does exist, I would ask that we have a marker down to, outside of this presentation, reach out to the Hospice and Palliative Nurse Association to get the number of certifications, and ANCC to get the number of nurse certifications in geriatrics, because those data are broadly available and they be included then in the, in this report. Thank you.
Thank you very much for your comment. One of the goals for this session is to help to at least shrink the gap in knowledge and information. And I think we have accomplished that task, and your comment certainly contributes. And at this point, I'd like to thank each of the presenters, the speakers, the panelists, those who are with us virtually, and you as the audience. And this concludes this session. Thank you very much.